All right, welcome everybody to the Neurocritical Care Society podcast. I'm your host, Nick Morris, and today I have the absolute pleasure of welcoming Dr. Allan Ropper. Dr. Ropper is professor of neurology at Harvard Medical School, where he formerly served as the executive vice chair of neurology and the Raymond D. Adams Master Clinician. He has over 180 publications on a variety of topics, from cerebral herniation to Guillain-Barré syndrome. He has been the lead editor and author of Adam and Victor's Principles of Neurology, perhaps the most widely read textbook in the field. And he is now primarily spending his time as the deputy editor at the New England Journal of Medicine, where he has most recently written several definitive reviews on topics such as cerebral venous neurosis, neurosyphilis, and transient global amnesia. Finally, he's mentored countless neurology residents and neurocritical care fellows, including me, and I'm really, really excited to have him on the podcast. Welcome, Dr. Ropper.
Thank you so much, Nick. Really appreciate you seeking me out.
As we talked about before we got started here, what we're trying to do a little bit is find some of the personal stories behind the origins of neurocritical care, and you were really there in the very beginning. So can you take us back to those early days at Mass General before the Neuro ICU was established? What were you seeing? What were you noticing that really mandated and inspired you to go on and help develop the ICU?
Thanks for asking. Well, okay, I'm going to give the whole story, so it's pretty elaborate.
Great, that's what we want.
The first is when I was training at the Mass General on White 11, which was the neurology ward, there was a room set aside in the corner, about 4, could fit 6 beds in there, where you could put ventilated patients. That itself was sort of a breakthrough. So we started to take care of patients who normally would be in what was called the RICU, or Respiratory Intensive Care Unit at that time, as neurologists. And that was a really odd thing. You have to remember, though, that in my epoch, virtually everyone, and certainly everyone in my trainee year, had done complete internal medicine residencies and were board certified in internal medicine. So it was okay. We did it. And I had spent a lot of time in San Francisco as a medical resident on several services that were very heavy ICU services. One was called CHEST at San Francisco General, where we intubated people routinely as residents and floated Swan-Ganz catheters. So I thought, wow, this is really great. Then Dr. Adams, who was my mentor, one of several, you're familiar with them, he retired, and Dr. Joe Martin came on as the new chair. And he asked me to stay on as a superannuated chief resident to sort of help him with the transition. He's such a great guy that I agreed to do that. I had already signed a contract to go into private practice on the South Shore, and in fact, put money down on a house down there. So it was a digression, but I spoke to my wife and thought about it and said, geez, I'd really like to do this. The year before, the biggest problem in neurosurgery was not technical at the Mass General. It was finding beds for postdoc cases. So Nick Zervis, who's very adept politically and personally, persuaded the institution to open what he called neurosurgical ICU. And I said, wow, if we're going to do that, I really want to be involved, because that's where those patients should be who are in that ward, in that room. And that's how it started. And I was lucky enough to be teamed up with Bob Martuzza as the neurosurgical representative. It was a triumvirate. And saw an extraordinary person named Sean Kennedy, who you really should try to interview. Sean was a neuroanesthesiologist, one of several. I learned everything about cerebral blood flow dynamics, respiratory care, resuscitation that I know from Sean. Very, very bright, wonderful guy. Lives in Philadelphia now. And that was my introduction to it. At that time, I was on call 24/7, 7 days a week, and took care of all the neuro patients. it afforded me an opportunity to get involved in some clinical trials. So I didn't know any more than an average person about Guillain-Barré, but a bunch of guys I knew at Hopkins decided to, under Guy McCann's guidance, start a clinical trial of plasma exchange for Guillain-Barré. And we had reported 4 cases, Vern Cavanis and I, in an abstract that we treated and did very well. So we got recruited into the trial. And once, just like everything else in applied sciences, once there's a tool, it drives the process. So we had plasma exchange, and we had a very great relationship with the blood bank, which did those. They do it almost on demand. So we started getting referrals from all over New England. We were seeing 100 patients a year. And so I backed into becoming an expert in Guillain-Barré. And then, you begin to concentrate patients with cerebral hemorrhage, subarachnoid, work with the neurosurgeons, and it took off from there. So I thought we opened the first legitimate neuro ICU in the country, particularly with that format. Dan Hanley says he was there first, and I'm willing to believe him. So that's how I got started. And then it just was gold. Everything we touched was gold. Brain death, everybody knew about brain death, but nobody was really scrutinizing it. Intracranial pressure monitoring. We were monitoring everyone and learning about how cerebral hemorrhage, encephalitis, and then mainly what's now called malignant edema, which is a terrible term because it sounds like a neoplasm. So we saw a ton of those, and we're writing stuff up. At that time, it was mostly descriptive, and everybody's moved on from that era, which is both good and bad. So that's the origin story from my end. And I was wrecked working that hard, but I had a blast. It was terrific. And we brought on some younger people as it grew. And then one of the things I started getting consulted, I was young at that time, by major institutions, sort of a joke, wanting to know how to set up a neuro ICU. And all I could tell them is you're going to run into trouble because the neurosurgeons want throughput. They want the beds for post-op. The neurologists want to take care of status epilepticus and that stuff. So we tried to define the field, and it was a hell of a lot of fun.
Yeah, that's tremendous. It sounds like you recognize this gap in care. I imagine back then, even because this still exists today, there was some resistance to the idea, and some perhaps some people thinking you were encroaching on their turf. Did you run into those challenges?
Yeah, and they were expected and mundane. The biggest problem, we managed to get along just fine with the neurosurgeons because the personalities they were very solid people. And there was a give and take, but we started to operate a little independently. The biggest resistance was on the institution's part because staffing up a unit like that was very expensive. And it was hard to understand where the revenue would come from. Ostensibly, it was from the neurosurgeons' increased cases, which paid very well. So I went to endless meetings about that. But ultimately, it sort of became indispensable for everybody. You got to understand that alongside this was a guy named Michael Wilson, 3 people, second person named Henning Pontoppidan, and a third, Mike Ree. They ran the RICU, and we had a wonderful relationship with them. They were on the 3rd floor. It was a more or less bread and butter medical ICU. And when I got really aggravated, I would start to admit my patients there when the neurosurgeons got in the way. And that sent a message.
Right. And logistically, as you were being consulted to set up these units in other institutions, how did you set it up? How did you go about training the nurses? How did you?
Oh, well, the nursing training was a lot of fun. We had a nursing training program that was both formalized that I created with Sean. We gave an actual 6-week boot camp type course. And then we had a lot of CME through the years and developed people like Mary Guanci and others who became major nurse educators. So that was a hell of a lot of fun. And actually, it's trite to say, but we did it together. I mean, I learned a lot from them. They depended on me to an extent, and it went back around. And when I went to advise people about setting up units, what I really emphasized were the pitfalls that I had seen that there were, and that the stylistic approach of an institution and the major departments would determine the configuration, not some imagined ideal way of doing it. And then, of course, the Mayo did exactly that. They took a lot of the basics, and Ilko, who was my first fellow, took that and ran with it and, molded it to the Mayo model, but still used a tremendous amount of the MGH sort of background spirit.
Sure. You mentioned Mary Guanci, and my boss, Neeraj Bajadia, says that Mary Guanci has trained more neurointensivists than anyone else in the country. Can you talk a little bit about Mary's role in getting neurocritical care going?
Absolutely. I mean, look, she was a bedrock for the nurses and the physicians. And while this is going to sound like old guy stuff, as people came into neurology and wanted to do neurocritical care, who had basically just had a year of internship, there was a big gap to fill. And Mary was instrumental in helping me and Sean write guidelines that would help people get started and have guardrails. And she was always a cheerleader and a wonderful, I would say co-executive in this. And then went on to create, of course, superannuated programs of her sort, of her own, that people emulate now. And there were several others. I mean, she stands out because she was the first, or one of the first, and so capable. But she also, she really understood the culture of the physician-nurse relationship at that time, which is very, very different than it is now. Mm-hmm. Because there was no handoff, there was no nothing. You did the work until it was done, and she stayed until the work was done, which is, a completely different sensibility. But it was good for the time. You have to realize that we had very few constraints. We probably made some major mistakes, I'm sure, both clinically and structurally. But there was an ease. I mean, you wrote a note about what you thought, period. No epic and so on. And it's easy for me to get it into a digression about that. Because
let's do that, because I'm interested, because you said you were on call 24/7. Mary was there until the work was done, which we know that the work is really never done. So I'm sure she almost never went home. And yet now more than ever, we're in our ICU and ICUs around the country, we're talking about burnout. We're seeing people leave the workforce. And yet I'm not hearing that that's what was happening back then. What's
nobody
the difference?
Was burned out. Nobody was burned out. We worked our tails off, but nobody was burned out. Honestly, I'm telling you, it's amazing. Now, I am reluctant to say too much about it because I have my own ideas about it, having to do with what's happened to medicine, having to do with the, I would say, cynicism of large institutions that really just want revenue cycle, but plaster it over. I have to say it because it's true. Even Epic, I think, is largely a fraud and has destroyed the culture, the clinical culture. So, why? I don't know. I'm not an expert on burnout, but we were very gratified, took great joy in the work we did. We felt proprietary about it. And I know it sounds like a dinosaur because you can't turn it back. People are voting with their feet. They do want lifestyle. There are secular trends that change that have nothing to do with medicine that make it more about balance. And I commend that. But there's been a confluence of things that have created a sense that, in my view, looking at the scene, fellows, residents, until 2 years ago when I stopped, that because there's not a proximity between the physician, patient and their illness, there's less sense of value added. It's that distance. And that's the feedback loop that kept us going. It was just really great to take care of patients at the bedside. I'm crestfallen when I go to visit other institutions and they ask me to make rounds in the unit, and it's basically hall rounds. And I've never seen anybody sitting down in a chair next to a patient's bed. Let me ask you this, Nick. Do you and your colleagues sit down next to the bed of every sick patient, even if they're comatose, every day on rounds.
I'm actually pretty good at it. We have a program in our ICU and in our institution called Commit to Sit, and there's a stool on the wall that is designated for the attending physician to sit down next to the patient. And I think it's probably the best thing we have at our institution.
Fabulous.
And I talk to the trainees endlessly about, you got to take the stool off the wall and commit to sit. And I agree with you, but I trained under you, so there you go.
That's my like sour grape stuff. Let's get on to more optimistic things.
Yeah. What traits do you think you had that made you successful in this?
Oh, I don't know. We all tend to believe our own autobiographies, and that's an old story. I honestly don't know. I guess I had enough ambition to do it because you had to have some drive.
You worked harder than anyone.
Oh, my wife's. I don't know if you heard that. But
I did. That's fantastic.
yeah.
You did.
Yes.
You worked harder than anybody.
Sandy was there.
With passion. So goodbye. I'm going out to the market.
Okay. Thank you. Maybe you should interview Sandy.
maybe our next episode.
He's very outspoken. So, but here, that's about all I can say. I knew I was ambitious and hardworking. A lot of people were. But I'm going to tell you honestly, and this is not false modesty, luck. Full stop. Luck that I got to train with Adams and Fisher, because Fisher in his own way was a progenitor of a neurointensive care type person, because he carved out stroke and he was very interested, not just in a little stroke, but big stroke. And
I think we've forgotten that. I mean, our residents, they know Fisher for the lacunar syndromes, and
it's a shame.
Yeah.
He wanted to know whether you should nurse a patient with a big stroke head up or head down. Was what was better for blood flow. He was interested in that. It was just luck. And then right place at the right time, right? The neurosurgeons decided that they needed more beds. And so the hospital opened this neuro ICU, and I was standing there with the correct training and background. And even subsequently, lucky to run into people like Sean Kennedy and so on. So, I don't know that there is a ensemble of attributes that makes you good at it in retrospect. When I look at fellows who I thought were outstanding, yourself included, I think they had a degree of range and personality that allowed them to take this on. And they were probably activists, right? If they had to run around every day and decide whether to give 500 milligrams or a gram of Keppra, and that was their job, their head would explode.
Agreed.
They needed to have something. They needed to have some operational outcome.
Well, how about the opposite then? Are there traits that you identify in yourself that made things more difficult for you, or that you had to work around to get all of these people to agree and starting this new unit and moving forward with it?
I didn't micromanage, but I'll tell you, once it was possible to check labs, I know I checked labs until 1 a.m. And that was counterproductive. There was no need. So you got to depend on your guys and gals, as it were. But that got in my way, and it still does, that I'm too detail-oriented, which, there's a sweet spot for that in medicine, much less neuro ICU, just enough.
Yeah, I think we're always trying to find the balance. Is there a case looking back that from the neuro ICU that just really sticks with you, something that you think back on as a formidable or pivotal moment in your career, or just somehow emotionally touched you, or whatever the case may be?
Well, there were a lot. Young head injury, because we used to see head trauma. The Mass General at the time was as much a community hospital. Well, I can tell you stuff that sticks. I had some Guillain-Barré patients that I felt like I nursed with the nurses. I was there with them all the time, reassuring them. We're intubated. We weren't quite as sophisticated at that time about sedation. And some of those people really suffered. And yet, when they got better, they latched onto me. They just would not stop thanking me. They gave money, et cetera, et cetera. And those people stuck. And there's one Greek fellow in particular I formed a friendship with, and a veterinarian who was one of the first people we treated with plasma exchange, who just bounced right back and was eternally grateful. But a case that would typify the neuro ICU personality is one that you simply could not get away with today, was the father of one of the neuro ICU nurses. Here was a man who was about 60, and he had a pretty sizable cerebral hemorrhage and was stuporous when he came in. We had CT, we didn't have MRI. You could see the edema around the hemorrhage was expanding. And we were monitoring his intracranial pressure with a bolt, which is something that's not used anymore. Now use these fiber optics, which, by the way, is not that much better. So the bolt we put in ourselves. Took a twist drill in the parietal bone. You made a little hole there. The neurosurgeon showed me how once. And then this thing had an outside thread. You screwed it into that. At a hollow center, you took a sound, punctured the dura. And if you could, you punctured the arachnoid. CSF would come out, and sterilely you attached it with a stopcock, really, to a transducer. Monitored ICP. We learned a lot about intracranial pressure on the fly. Anyway, over about 3 or 4 days, he got worse and worse. His ICP went up and up, no matter what we did. And you know this happens in big stroke as well. And it was a ganglionic hemorrhage. It reached fairly far superficially. So I said to this young woman, the nurse, I said, look, the surgeons will not operate on them, because at that time there were doctrinaire about this. And these are trends that come and go, and they were wrong. I said, I'm willing, if you're willing, to do something completely unorthodox. I will take a ventricular needle, large bore. I'll disconnect the stopcock and I'll try to drain his hemorrhage through the needle.
Oh, wow.
I did this with Len Wilson. And all we did was attach a 30 ml syringe to the end of the ventricular needle. And looking at the CT scans, which we had up on a view box, I just guessed. And I put this thing into the hemorrhage. And it was under such high pressure that it pushed the 30 ml syringe to the top. We got another syringe and he woke up.
That's phenomenal. I could not imagine.
Can you imagine doing that now?
Doing that. No, absolutely. I'd lose my job before I even got started. Yeah, if I just had the word out.
The neurosurgeons might be willing to evacuate it because we know a lot more about the progression and so on. Although you know as well as I that the randomized trials are ambiguous at best on this.
Yeah, we do. We've started doing a lot more of these minimally invasive clot evacuations. We're waiting for the enriched trial outcomes to be reported, but I think we're all excited about the results we've been seeing. Yeah, but that's an incredible story.
You'll send that trial to the journal, right? If it's good.
Yeah.
Okay.
Well, I'm still blown away by you evacuating a clot at the bedside. It just shows how much really things have changed, and even when you're acting in the best interest of the patient, with shared decision making with the family, there's still very little allowance for going outside the bounds right now.
Yeah, I would say that under the proper circumstances, and I felt that they were there, the wife, the daughter, who knew very well what was going on, they all agreed.
Mm-hmm.
And I even told the neurosurgeons I was going to do it. Now it ends up, and I didn't tell you the end of the story, that the edema was so massive that it over the next day filled the cavity and he became brain dead.
Oh boy.
So that's why I held that till the end. I always wondered, did the evacuation somehow enable the edema or something? On the other hand, this man was going to die. He was already had one fixed pupil. So.
Right. You mentioned, I think, the primacy of intracranial pressure monitoring, and it strikes me that we're at a time now where we have these other monitors, and we have them here at University of Maryland, microdialysis monitors, cerebral oxygenation, the Lycox monitoring, and as you know, just like in those ICH trials, although we don't have great trials of randomized controlled trials for monitoring, and they're just monitors and they're not therapeutic devices. We've never really shown benefit from ICP monitors in the best trip trial, and yet that's become standard of care. But measuring brain oxygenation and cerebral microdialysis, it's been really hard to get people to accept doing so. And I guess in your mind, what's the difference between those? And do you think those are monitors that we should be utilizing more in different ICUs? It was pretty late coming to Mass General. I know they're doing more monitoring now.
Yeah, I don't know. There is a question of whether are you going to utilize that information to have a feedback loop that would make a difference? That's the essential question.
Right.
And you can. I mean, you could try to manipulate blood pressure and oxygenation and all those other things. I'm afraid that the impediment is not on the monitoring side, which allows you to appreciate what's actually going on. It's much more that I think we have a very, very limited idea of when the point of irremediability comes. In other words, I think we're taking care of people after the essential pathophysiology is done. We're trying to hyperoxygenate, cool, hypertension for, say, cardiac arrest. I actually think that's a doomed project. I mean, you could see it's doomed. Not because the monitoring is wrong or not essential or interesting or tells you what's going on. I just don't think we have figured out the efferent loop of that at all. And frankly, I think that neurocritical care is stuck in a rut because of that. Through no one's fault. Everyone's chipping away and trying. But we do not know. We have no way to actually change the physiology. We're floundering. And I think we want to be careful about overcommitting to the monitoring because it provides such a tangible way of understanding what's going on, gives you a sense that you can change things, and you're trying for sure, probably for the better. But it looks to me like it's almost futile. And there's an interesting analogy because I don't know if you're aware. That's the other thing we did, by the way, routinely in that neuro ICU. We floated our own swans constantly. Certainly a CDP line, but swans were considered. Oh my God, you got to go to the cath lab. Are you kidding? 2 a.m. we were doing it, and now it's apparent that there's no benefit derived in managing acute congestive heart failure with a swan. And it may be the same kind of thing. Now, it's a little bit facile to say that because in the background, the underlying practices have improved so greatly. We don't let people get hypoxic. We don't let them get febrile, et cetera, et cetera. So now you're looking at smaller and smaller increments. So that's a backdoor answer to your question about the monitoring. I think it gives us a sense we're doing something. I don't think we're doing much, but I want to say something. That is a minority opinion among my colleagues.
We struggle with this dichotomy between the primary and secondary brain injury and the minor effects we can have on the former. That probably have more to do with ultimate outcomes than the latter. I guess if you said we're stuck in a rut, how do we move forward?
We need more people to go back to be clinical investigators. When I started the unit, Nick Service gave me a lab, and I did a series of blood flow experiments with gold-tipped cerebral blood flow electrodes in rats and rabbits and experimental cerebral hemorrhage. And there was a lot there. I couldn't finish the work. I don't think we have enough hardcore physiology investigators. Now you do. Some of your former colleagues from the MGH have done terrific things in the lab. I think that could kickstart this. But you said secondary injury. I don't think we're doing much for secondary injury either, except to avoid doing harm.
Yeah.
And that's that background trend that's changed. So initially, you kept people out of trouble, but you went, oh my God, their cerebral oxygenation is way down. What's going on? Now we wouldn't even let that happen.
Right. Is there a role for the new mobile stroke units in all of this, in expanding their kind of utilization beyond ischemic stroke?
Yeah, probably, but not much.
Not much.
Look, not much in its current incarnation. Eventually, yes. Jim Grotta's stuff from Houston's very provocative. The effect sizes are modest, very expensive. And again, as the systems in the background get better, you encroach on that. But I think it's a terrific idea. And again, you learn from it. That's the problem. People always are transactional or operational. They want an answer out of this. And they don't realize that there is no other recourse but to try it and try to learn something from it. Not necessarily, it's a positive or negative trial. I don't even like those terms because all these trials contain valuable information, whether they hit a p-value or not.
You mentioned that what we need are more sort of physiological research, better primary understanding. What are the major areas you think that we should target in neurocritical care to move us forward?
Well, I would say head injury trauma, because that's been a bit of a wasteland. And there's an assumption that there's a lot of secondary injury. We don't really know that there is. In the early work at the NIH by Omaya and others, they were unable to demonstrate there was much secondary injury. Everything that happened for self-evident reasons, trauma. So I think we need more on that. And it may be an immovable object. I just don't know. Look where big answers came from that were unexpected, right? Thrombolysis, thrombectomy, out of nowhere. All of a sudden, stroke care, critical stroke care is changed forever. Mm-hmm. And in a big way, not a small way. And till somebody decided to do it, it didn't exist.
And then what excites you the most about the future of neurocritical care? Where do you think our next breakthrough is going to come from?
Nick, I wish I knew. I think that's up to you and your generation. I would not have anticipated thrombectomy, and that was a breakthrough. So I think you just don't know. And quite often, as in the case of endovascular, it came from cardiology or someplace else. Mm-hmm. So I really don't know. I think the commonality in neurocritical care is the obvious one. These are people with otherwise potentially mundane neurological conditions that have gone to the extreme. That's what unifies them. So we need to look at the extremes of brain pathology, brain, physiology, pathobiology.
Yeah. No, it's interesting as it refers to trial design. I think some of our trials, they don't really capture the patient population that we're really interested in. I think the one that comes to mind maybe would be something like the PATCH trial, where looking at platelet transfusion and ICH, and these are mostly smaller hemorrhages that we're not too concerned about anyway. Most of them would have done pretty well.
Right. That's true, of course, of all big clinical trials. You are obliged to confine the patient population, to constrain it, or otherwise you can never get it done. But I don't know what the future holds. However, I would say that just like when there were big jumps in the past, it seems poised to do something.
Yeah,
what exactly? I don't know.
I hope so. When I was a resident at the Brigham, I never got to round with you in the ICU. We spent, I think, a lot of time in clinic together. Of course, a lot of time in morning report. And I remember I was on, as I went from, I think, a PGY2 to a 3, is usually took, if I remember, the first inpatient block of the year. And we had like a record number of admissions that day, which was par for the course for you. But when you rounded in the neuro ICU, did you have any particular way you like to round, or any kind of rules, something you were really a stickler about?
No, not really. We walked around, we did everything in the patient's room, and that's changed. But no, I wasn't doctrinaire about anything. And I never felt as if I was much more than the orchestra leader. One of the things about critical care, tell me if I'm wrong, neuro ICU guys don't like clinic.
I interview, we're in the middle of fellowship applications right now, and I hear again and again, why are you going to neuro ICU? And they say, oh, well, I just really didn't like clinic. And I know,
so that's actually a shame, because following up on these patients, instead of, sorting them out to the neuromuscular service because they had GBS or whatever, or stroke people, that's I think, unfortunate. I really do. You can have a circumscribed clinic and learn a tremendous amount because we don't teach the full trajectory of these illnesses. Even people who remain badly injured with head trauma, grappling with that is very useful when you're dealing with it in the unit. So that's number one. Number two, you said we had a record number of admissions. Okay, I believe that I hold as a resident the record, the MGH record for number of admissions in one day. And I have proof. 32.
30, that's more than I ever had, that's for sure.
Yeah, it's more than anybody ever had. But then again, we could write a quick note.
Right.
Although Dr. Adams liked the notes typed and he liked the history in black and the exam in red. So we change ribbons. No joke.
Oh my
gosh.
But
those notes, go back and look at those notes if you can. They are a wealth of clinical material. It's how Fisher operated.
Mm-hmm.
We're not doing that now. We don't appreciate the hour-to-hour, day-to-day changes in our patients. Instead, we just record a Glasgow coma scale. Right. And if you speak to, Jeanette, those guys who originated the scale, they said at the beginning, don't do that. That's not what it's for. So we got to the shorthand, and we don't have the broad gauge view of what we're doing. And I think it's unfortunate.
Yeah. You mentioned clinic, and I think this is something that's really becoming more and more of a hot topic in neurocritical care. We've started, my colleague Melissa Moda and now Gunjan Parikh and Gary Schwartzbauer here at Maryland have started what we call the Neuro ICU Recovery Clinic. So and we made it available to our fellows who all said they really wanted to go to clinic. They wanted to see these patients. And in, I think, 3 or 4 years, we had one fellow or two fellows actually take them up on it. And they loved it so much, they wrote up their experience, and it's published in Neurocritical Care. And yet we couldn't get our fellows to actually attend the clinics they said they want to. So what are we doing? We're making it mandatory, because I think I agree with you. It's important. And yet I don't go myself. So is it mandatory? Should we be forcing intensivists to have clinic?
No, I don't. You don't want to force anything on people. They have to be enthusiastic.
How about trainees? We can force things on trainees, though.
You can, but I don't know the answer to that. I'm always a little bit hesitant to make people do stuff. If you want to learn, you will learn.
Yeah.
So it's a question of how people view what they're doing, and things have changed.
Was there any management question in the ICU that you just couldn't have cared less about? The trainees really stressed about some question, and to you, it just was missing the bigger picture.
Foley's.
Agreed.
The mania around Foley care. It's the drunk looking for the keys under the lamppost. You can do something about it, so you can write a long list of rules. But I'm using that as a placeholder for about a dozen things like that, which are important, but are beside the point.
Well, that lives on today. I'll tell you, we talk about Foley's constantly.
Well, because you can.
Yeah. I mentioned morning report before, and I think that was in many ways the most important part of my training as a neurology resident, and what I enjoyed most about my residency. And that was, of course, led by you and Marty Samuels. And it really put us, I don't want to say on the hook, but it made us responsible for being able to coherently, cogently explain our diagnostic reasoning. And over time, it's gotten harder and harder to ask trainees to explain themselves or to describe their diagnostic reasoning. I guess, what do you see as the value of morning report, and how you obviously prioritize that in your career? Is that something that we should all be doing, and how do we do it now with the changes in
I think so. Well, let me close the door. Now I'm going to be politically totally incorrect. If you ask residents, even fellows, like, what do you want to do with your career? About half say they want to teach.
Yes.
And I think that's tragic because to teach something in depth, you have to know something. And the only way to have deep knowledge of medical illness is to have experiential knowledge. So you can certainly put together fantastic educational programs that have guidelines and have diagnostic, diagrams and red flag type things, and they're very, very important. Don't get me wrong; they form the basis of getting people started. But if you stop there, which is where a lot of places and people have stopped, you're done for, because I'm already seeing that the generations who have stopped there are now in charge of Morning Report. And they're wonderful people, and they're very bright. And in their area, they know more than I do. Epilepsy, neuromuscular, so on and so forth. But that you can't do Morning Report that way. You have to develop a depth of understanding of how certain diseases change the nervous system. And the most important part of that, and this is what I kept an ear out at Morning Report, is that there are things that simply can't happen. And when you hear people raising them as possibilities, you realize you've failed.
Mm-hmm.
The way to get at that is still through clinical pathoanatomy, which isn't done anymore. So you have to take the next best thing, which is a case-by-case basis. But, it's fine to say that somebody has a lacume, referring back to Fisher. But I wonder how many people have actually seen a lacume. Probably none, right?
Right.
It's fine to say, people have critical carotid stenosis. How many people have cut a carotid that was critically stenotic and looked at whether there is intraplaque hemorrhage, which there isn't, by the way, except rarely. Why it's critical. And the whole thing, what's a real mess right now is microthrombi, microemboli. Do they even exist from a carotid? I don't think so. Or if they do, they're not clinically important. So what I'm getting at is the Morning Report is an attempt to bring together all types of neurology and think about it from the bottom up and not algorithmic.
Right.
That's what Marty and I tried to do by sharing experience. And I think it's very important, but you have to have a cadre of people to do it.
Yeah.
And then you have to have people who want it, because everybody's rushing now.
Yeah. No, I think it certainly shaped my my skills as a neurologist, that this bottom up approach as opposed to an algorithmic top down approach. And I think I've struggled with that, honestly, as an attending clinician, where perhaps our trainees don't have that same experience.
Well, they can from you, Nick. They can, really, because you appreciated or at least absorbed the essentials of it, and it's not challenging. That's the other thing too. I mean, if people's egos are bruised so easily when you ask them, tell me why you think that, then you're not going to get anywhere either.
Been tough. You mentioned Dr. Samuels, or I did, both of you did, and he's obviously been a close collaborator with you, and I think you're still writing Victor and Adams together after all these years. How has he kind of had an influence on your career and vice versa? And what's it like to have some kind of, I imagine he's a bit of a sounding board for you. And
Oh yeah, we bar for each other. Look, he was the chief resident in neurology when I was a junior resident at the Mass General. He had taken a year off to be chief medical resident at Boston City, came back, Adams made him chief resident, and I was a junior resident. And in those days, the majority of learning was done vertically like that, from upper level resident to lower level resident, as it was in medicine. And there was a lot of experiential knowledge embodied in that too. So he was a close friend forever. And then when I decided to leave St. Elizabeth's, where I was for 12 years, it was a marvelous place to work in Boston. He said, why don't you come over here? We'll collaborate. And, I did. And it was really, really a lot of fun. tried to develop new programs, expand the reach of the Brigham Neurology. I brought Mike Hayes and Greg Alam in and other people from my Tufts days. So yeah, no, look, Marty is an extraordinary teacher and is a very, very careful observer and grew up in that Adams, Fisher, Richardson, the three horsemen culture. So we shared it. And that helped because we could be supportive of each other in these ventures.
One thing I hear from my fellows as they're looking for jobs is they're concerned about leaving academic medicine because they say, if I leave academic medicine, I can never come back, right? That's the deal. And you just mentioned you went to St. Elizabeth's, which I remember once in Morning Report, one of the residents was presenting a case that had been transferred from there and they called it the outside hospital. And he pointed out that they actually had a roof there and walls and everything. Is that true? How did you do this? And are you an anomaly or is it possible?
No, okay, so here's a dirty little secret. The best clinical neurology is done in private practice because these are people who are steeped in day-to-day work where they really have to deliver and they know a lot about that stuff. Unfortunately, that is not largely inpatient or it's certainly not critical care. But the best clinicians after the previous generation that I knew of neurologists that I've encountered over time have been in private practice. It's just that it can be somewhat isolating and everybody is spoiled because they're in an academic environment, which feeds from the bottom and the top. You can go back to academics from private practice, undoubtedly, if people need you and you've developed a skill set and you can describe that. It is a little harder to break in, but only because programs tend to want to play it safe and will hire their own people. There's a whole other axis of this, and that's people going into industry. Mm-hmm. You can come back into academics from industry too. That's a little tougher, but it's doable. You do lose your skills if you stay out of the game for a while.
I think that'll be very reassuring to some of my fellows currently. I want to talk about something interesting in your career because I was a resident when your son was a resident in neurosurgery. And what was it like, as someone who works in the neuro ICU and works side by side with neurosurgeons to have a son in neurosurgery? Well,
he went over to the dark side, what can I say?
How did that happen?
I know. Yeah, no, my Alex is he's very skilled with his hands. He did the right thing. Listen, you're prideful, but you want to keep it tamped down and you certainly want to stay out of his way. So, but it was a very special experience. Of course, those guys are tortured. My God, it's like the Inquisition. I don't know how they survive it. They're hardcore. But let me say that I believe that neurosurgeons are one of the last groups to have retained a complete clinical commitment, complete, day or night. Part of it is because their craft and their work product is who they are. So they take a lot of interest and pride in it. We could use a little of that. And it was good to see him do that. And I still think he does. And I know to this day that he's successful in part at Baylor because he sits down. He uses your metaphor. He talks to every patient, makes rounds every day. There are no surrogates in between. I mean, he's got terrific fellows and residents, but he still takes personal responsibility end to end. So it was great. It was great to see him do that, but that had to do with the Brigham culture, which is, pretty damn rigorous is an understatement.
I do remember that. I definitely spent some time on that service, both as a medical student. And then I was, I think one of the last classes that I had a rotation in neurosurgery during my residency, which I think has gone away in most programs. And it's a shame because I really learned to appreciate what they do and the commitment there.
I think it's a shame too. We operated as neurology residents who rotated for either 4 or 6 months through neurosurgery. And you did the subdurals after they showed you the first one. my mentor there was Roberto Harros, fantastic, iconic neurosurgeon who used to say, Allan, don't suck on the brain. Be careful with the sucker.
That's great. We're coming to the end of the hour. We have a few kind of quick hit questions for you that we've been trying to ask everybody on the podcast. Do you have any passions or hobbies outside of neurology?
Oh, yeah. My problem is I have too many. I have been since age 13, a very avid amateur radio operator. I also am a big time model train guy.
Oh, wow.
So
I wish I could describe this for people on the podcast.
And it's a lot of fun. So I've been working on this for about 2.5, 3 years. It's got a couple more years to go. And I also, as a hobby, collect and restore antique American pocket watches.
Oh, wow.
60 of them. So yeah, I have a lot of hobbies, and I'm a maniacal golfer. I'm glad you brought that up, because I think one of the things that's missing, everybody's burned out, is recreation.
Mm-hmm.
I mean, real recreation. It's really it's a time warp thing. I can't play 18 holes of golf without getting interrupted because of the journal, because the copy editor is writing me, emailing me, phoning me. But people don't take advantage of recreation, and golf is the greatest, man. I mean, you can play 9 holes in an hour and a half, 2 hours.
Well, I had no idea that you did all these things. How do you work this into your schedule? How do you find time to do it?
You do it in between because it enlivens everything else you do. That really, I mean, I see it as one big thing. You can't be monolithic or monochromatic. You can, of course, but you need stuff. On the other hand, I think that it's important not to take your eye off the ball, which is medicine.
Then if not for neurology, maybe I think I know the answer to this, but if not for neurology and neurocritical care, what other specialty would you have liked to have done?
I thought I'd do cardiology, and I did a rotation at the Mayo Clinic, which was fabulous, but this is maybe telling. Valentin Fuster, a name you may or may not know, but is very, very important American cardiologist at Mount Sinai now, also was at the NIH. He was the fellow, and we had a ball on my sub-internship there. But it was just as cardiac cath and echo were coming in a big way. And I said, I don't think I would be value added as a clinician with my skills anymore, because nobody's going to care if I can tell mitral stenosis from aortic regurgitation. It's all going to be mechanized. So I thought neurology still had some running in there. So I think I might have been a cardiologist, and I almost was.
And what specialty would you not like to do?
Oh, I don't. Everything else.
Everything else.
I mean, I don't know. I don't know. I haven't given it much thought. I loved rheumatology, but these are things, you meet charismatic people along the way, and spectacular teaching in that. I said, wow, this is great. And it so happens that in my medical residency class, almost everyone went into either rheumatology or oncology.
Interesting.
Sort of odd, but it had to do with the personalities of the time.
Yeah. Is there a sound or a smell from the ICU that you look back fondly on or remember?
You guys didn't experience large gymnasium type wards with Melena.
You look back fondly on Melena.
It reminds me of these really antiquated, horrific, huge wards at San Francisco General Hospital. And I and my colleagues who trained at the same time, Peter Stone, people like that, we talk about it all the time.
Yeah. Well, then the next question is there a sound or smell in the IC that you just hated, that you couldn't stand? Is it the same answer?
No. There wasn't a lot of Melena there. It's the damned alarms, man. The beeps.
I don't hear them anymore. I spend too much time there, I think.
Yeah.
They're overwhelming. And then lastly, as we wrap up, what advice would you give to the fellow about to embark on a career in neurocritical care?
It can only be superficial. I think that try to be a first among equals in the field. Don't just go along. And I will say this, I believe that there's still a tremendous amount that can be done, even clinically. I mean, I endorse the idea that we need more laboratory investigators, but I still think there's a lot clinically, and it's not just trials. It's just you have to generate the right idea and approach it and build it up from the bedside. And then if you need to, if it's appropriate, then you try to engage a bunch of people in trials.
Yeah.
And get into trials, join some trials, be site investigators, or at least collect the data. It's a very effective thing, but don't get slavishly devoted to trials. They're not the be-all end-all.
Okay, well, you've heard it first from a deputy editor of the New England Journal that trials are not the end-all and be-all.
Absolutely not.
Yeah, we'll let that be the last word for the podcast. Thanks so much, Dr. Ropper. It's been an absolute pleasure. Well, thanks, everyone. I hope you enjoyed this episode of the Neurocritical Care Society Perspectives podcast with the great, incomparable Dr. Allan Ropper.